And welcome back. It's now 7 o'clock, and as promised before the break, one of our segments has to do with the Belize Taiwan Renal Failure Prevention Project. And joining us for this conversation, we have Dr. Fang Yi Lin, President of the Far Eastern Memorial Hospital. We have Director of the Taiwan International Cooperation and Development Fund, ICDF, Kathy Wang. And we also have Deputy Director for the Medical Services Department from the Ministry of Health, Dr. Francis Moray. Good morning, and welcome to the show. Now, Dr. Moray, let's start off talking a little bit about this partnership with Taiwan and how the ministry has managed to pull this together.
Okay. Thanks again, and good morning to all. Basically, as we transition, as the country transitions epidemiologically, various studies have shown that some of the most common diseases that exist in Belize, for example, the chronic diseases, or what we refer to as non-communicable disease, principally diabetes, hypertension, are two of this group of family that contribute to what we call chronic kidney diseases, or some other persons would refer to it as a fatal outcome of chronic renal failure. And so various projects that have been, or research that have been done locally, for example, the CAMNI study that was done in 2010, showed that Belize is, that the region of the Caribbean and Latin America, and of which we are part of, has one of the highest prevalence of diabetes. As such, research that has been done from the epidemiology unit at the Ministry of Health, along with collaboration of PAO, continues to show this, this trend, which is even increasing in our country. And hence, the collaboration with Taiwan and ICDF, as a result of, this is a follow-up visit that was done and a study about 2 or 3 years ago. This collaboration came to fruition, in which various of these factors that are exist in our population, for example, high blood pressure, the diabetes that might be increasing according to the different regions in our country. We're seeing that the north has more diabetics than the city, that the patients that are dying of diabetes and its complications are mostly from the Belize city and compared to the south of our country. So our country is unique in that the risk factors and the diseases are spread out, but some populations or some areas are more affected from others. Mm-hmm. And so using this as a base and the research that was done, the collaboration came to be with ICDF. Mm-hmm. This project basically kicked off about 2 months ago after the agreement was signed between the Ministry of Health and Taiwan.
Mm-hmm. As a follow-up question to what you said, you talk about the subpopulations. Where will the project focus on? Will it be on one of the higher risk areas, or will it be national in scope?
It's a national program. It's we're basically, as you said before, it's a prevention collaboration project, and basically it's hence a national program.
Let's get Kathleen into the conversation in terms of talking about it from the ICDF standpoint, in terms of being able to find the right links within Taiwan itself to be able to assist with the Ministry of Health's project.
Okay, so good morning, everybody. I'm very pleased to present to you, why the Taiwan ICDF with the Ministry of Health, and we also mobilize the private sector resources like Far Eastern Memorial Hospitals. It is because we recognize the importance of this chronic disease in Belize. We also think that with limited resources, we need to mobilize our private sectors jointly to implement the projects. It is because we can just have Far Eastern Memorial Hospital as our backup team, because they serve as consultancy, professional consultancy, and they have a human capital investment. They also have financial resources. So we are very honored to have them to collaborate with the project with the Ministry of Health.
Yes.
This is our pilot in Central America, and we expect that, and we treat these projects spearhead in Central America to not only to Central America and to Caribbean countries.
Now let's get Dr. Yulin into the conversation. You are the president of Far Eastern Memorial Hospital.
Yes.
And it is a well-known hospital in Taiwan,
Yes.
and also well-known for transplants and some of the
Yes.
surgeries that you
Yes.
conduct there. Why was it important? We know the hospital itself does a bit of international work, but joining with ICDF to do a full-term project like this,
Yes.
what are the benefits for the hospital?
I don't think that the hospital has any benefit from this. It's just human aid. We educated students or residents talking about to aid the people they need when they necessarily want. And by assisted this project, I think we can help if it success, we can help the people in
Better trained.
Yes.
Yeah.
And I think through this cooperation, we and ICDF, we can run a project previously already done in Taiwan. Taiwan, we have also have a high prevalence of chronic renal disease.
Really?
Yes, and we, through our effort, epidemiology and anything, and we get the control in some way. So,
What's the situation of diabetes in Taiwan?
diabetes is not grave, yes. But for the chronic renal disease, Taiwan is another etiology due to hypertension or chronic infection or something stone. And previously we think that probably diabetes or something can make this. But actually after the epidemiology survey, we found that the herb drug make big damage to the Taiwan people. So after the survey, we asked the people to stop the herb drug intake.
Now, looking at the partnership itself, how will it actually work on the ground?
Okay. Well, basically, just to expand on what Dr. Feng was saying is that, for example, if you notice, we have different epidemiological profiles. What is traditional, the traditional causes of chronic renal failure in our scenario is different in their country. The project basically has 4 different components. One of the biggest stronghold or part of it is prevention, health education, and promotion. We at the Ministry of Health, we've identified, and we are actually working on building somewhat of what we would call not a registry, but building a cohort of individuals who we've identified that may have chronic conditions like diabetes, high blood pressure, that have what we call renal impairment. That by some lab tests, these individuals have been shown that they have, like for example, protein in the urine, or they have a elevated liver kidney function test. So having that data will allow us to to work our physicians in the field, on the ground, work a bit much more on being able to interpret what they're seeing, and in so be able to educate that person much more on how to manage his disease. And for our scenario, it's mostly diabetes, high blood pressure. We are also talking about kidney stones. We're talking about kidney, infections of the kidney. We don't. These are the traditional diseases that produce chronic renal failure. On the other scenario, we have what is happening in Central America, in which El Salvador, Nicaragua, Honduras have been affected by chronic renal failure by the use of pesticides in their country. And so we don't know of that scenario in Belize. We suspect that it might also exist because it's a slow progressive disease. And so for us to build information, we have to go out actively. And so this comes to the other part, doing surveys, which is the community survey, which we will, hopefully within the next 6 months, have this project on the ground. And therefore, what we need to build capacity. And so if we already identified people who are sick with the disease, we have to build capacity, train our physicians and nurses to have the capacity to identify, to monitor, and to treat those who are affected. But even so, use that capacity to prevent or to be able to treat those who are already sick from getting to that final stage of which we all don't want to get to. And so those are basically two of the components. There's also, three components. There's the community survey, the epidemiological data gathering, the health promotion aspect, and also the building capacity. So there's basically 4 issues to this.
So this project will definitely be a major stepping stone in terms of the country's response to persons with NCDs, specifically hypertension and diabetes, but also in understanding some of the root causes as to why we're ending up with renal failure. One of the challenges we face in Belize, and we've heard countless stories, is when a person ends up at the point where their kidneys have failed, there's very little hope left for them. Dialysis can only be sustained for so long. Opportunities for transplants are just way too costly for many people to leave the country and pursue those. And even if they do, the cost of the medication is prohibitive. In terms of what your hope is in terms of monitoring the people within the cohort, is the objective to be able to, what would you like to achieve with the cohort that you have established?
Well, basically, the main function will be to improve their control of their disease.
Yeah.
And so if you notice, diabetes is not the doctor's control. I mean, doctors can prescribe pills and insulin and in an increasing dosage, but it's the management that is a personal issue. That person needs to know how to manage his disease.
Yeah.
And in so doing, we have to be able to build that person's response and in saying, teach him what to eat, what food he should avoid, how to do calorie counting. So it's basically educating that person, the family, and the community. Because in the future, the response might be slow, but it has a generation effect.
Yeah.
Meaning that we need to begin from the younger generations, be able to educate them on what it means to exercise, what it means dieting, what it means avoiding certain types of food if you have that family history of certain diseases. So we have to go from generations building knowledge and decision making, because if you know that you have a family who's diabetic and you're a bit obese, then you know you must exercise, avoid high calorie intakes, for example, fruit juices and Coca-Cola and stuff like that. That might just trigger you becoming diabetic sooner than you should have been. So these are things that we need to establish. And in having that cohort, it's being able to identify them and say, our physicians, our nurses, you need to identify these individuals, tell them or advise them on how to manage their disease. And so to delay the process, because if you're diabetic, it doesn't mean that necessarily you will fall into disease. It is a slow disease that produces damages to your blood vessels, it produces damage to your nerves, and eventually the kidney disease might appear 20 to 30 years in the future. But now that you have been diagnosed and you're doing everything that is wrong, we need to advise you now and not let that complication arise in the next 5 years.
In addition, we also take advantage of Taiwan's ICT. So this project will also strengthen the health information system to facilitate chronic disease tracking and management, which is very important to follow up those patients.
And that was the point I wanted to get at, because a big part of the challenge for Belize has been tracking families over time. And with this support, how do you intend to build the health management information system?
The BHIS is an innovative health information system. It's complicated as well. And so we have to build our capacity for our ITs to be able to, our biostatisticians, people who work with the BHIS to get the information out. And once that is done, then we'll be able to have that information converted into, that data converted into information, and from there possibly into policy. Because essentially, if we don't get that, if we don't build capacity internally at the Ministry of Health, you can have all the expensive health information systems, but if you can't get out the
but
data
if there's no
information,
input,
and if there's no input on the other end, so we have to lobby from the user standpoint. I mean, the physicians who need to put in information, they need to put in a diagnosis of individuals at risk or individuals who are already with the disease, so we're able to extract that information. There are various things that they have also an IT person has come on board.
this is great.
IT professionals from Pfizer Memorial Hospital join us. So the following days, they will have a close discussion with HIS departments.
Yes. And this is basically for us to be able for them to modify the BHIS, to give us these alerts when a person has been diagnosed or a person who is at risk. And so we'll be able to send that information to the regions and for the physicians, and to be able to follow up in this person when he comes back into clinic.
I want to focus on one aspect that you spoke about, and that's the health promotion aspect. Because Dr. Moria, as you said, it really is the most important thing for a person with diabetes to know, is that they will be the ones managing their care. A doctor can prescribe, a nutritionist can give you a meal plan, you can be told to exercise more, but at the end of the day, it is self-management. What can be done, and we hear physicians talk about this, we hear people from the Diabetes Association talk about this. It is just generally a challenge that we have in getting people to change their lifestyles. What's some of the practices that you have perhaps used within Taiwan or within the hospital that you have found to be effective when working with patients who are facing quite detrimental conditions like renal failure, to get them to make the shift in their lifestyles?
If they are already got the renal failure, in that stage, it probably is too late. So in the beginning, we have to monitor some important index about the patient's body weight and the blood sugar, and now they have A1C. That is can monitor your 3 months sugar. It's
the one that tracks how high or low you go in 3 months, right? The sugar.
So
even if you have a good day today, it'll show how you were the past 3 months.
Yes. So we have to frequently notice the patient, his condition about the diabetes, and give him instruction about the diet, and discussion with him frequently.
Yeah.
We also will invite the family members to join the health education, which is very important. You know, when the patients they get sick, and normally the family member is the key, I would say, stakeholders. You know, you need to take care of them and always remind them when you need when you need to take medicine, and also need to pamper your the family. So, which is very important that its family members join. And what time? Sometimes when the patients in Taiwan, when the patients wait for the doctors, and there's a TV, always have a health education programs, or the nurses or some of health workers, they will just give you health education. So that's how we think that not only the patients, but the whole family, they need to support them. So this is, I think, the key to the success.
Dr. Murray, what has been the buy-in in terms of the Belize Health Information System? What are some of the challenges in terms of making it fully operational?
A few of the challenges that we have, one is the human resource component. We have the user, there's basically two ends to the BHIS. Where the information is being put into the system, meaning the user, the physician who needs to put the information there. The clerk who, when you come as a patient, you need to give that person your correct name, address, age, date of birth, etc. When you come to a visit, each visit you need to bring your ID card, which is a must. The same when you go to a bank, you want to cash a check, you have to take a passport or a social security. That's a challenge. Belizeans on a whole sometimes just don't take their cards with them. And so the person on the other end may fall into or receive resistance from that person coming to access healthcare services, and so they design a new number for that person. And so that becomes a challenge. One person having 2 or 3 ID numbers. And so there's duplication of personal information. That becomes a challenge in which you have to clean up information. And so you spend hours and hours cleaning up information from one person. 2, then the physicians who may not be putting the information into the system, which is a challenge. The BHIS, it's new to our country, but we have a limited number of individuals who can actually manipulate getting out information from the system, and that's not only at the regional level or district level, but also at the Ministry of Health. And so that also becomes another challenge. The other challenge is modifying what you need to put new queries or new tools that need to develop within the BHIS. And so that becomes another aspect where the financial resource comes about. So this project also involves modifying that BHIS, because you know that we, even though we have property rights to the BHIS, there's also the company that built it or designed it, so we have to have accessibility into modifying what is there. So that the economic aspect is another challenge. Every time you design something, you want information, you have to change. And so it's a continuous challenge in getting information from the BHIS.
Is it mandated for the private sector to input the data into the BHIS?
As far as there are certain policies that need to change, and I think that the Ministry of Health is looking into that. That's been a challenge for years. People, the previous directors and deputies who have been there have been trying to get this on board. And of course, I think it's a challenge for our present CEO and Minister and the new Director of Health Service to see if this comes about.
And I want to come back to Kathy, because when you look at this, you talk about this being a pilot project. How closely is the monitoring of what's happening here to walk away with some of the best practices? We know that you started a couple of years ago in terms of the steps to actually get to this point. What have you learned so far, and how do you think this will inform you as you continue to roll out the project?
Well, I think I can start from two phases. Before this project kickoff, actually, we worked with Faisal Memorial Hospital. We come here 2 times. One, the first time is identification mission. The second one is appraisal mission. So the first time we just go the whole countries to understand the current situations and to identify how we can proceed and how we should just focus on. And the second phase is appraisal mission. That means we closely discuss with Ministry of Health, and we also visit many hospitals, and we even talk to the kidney diseases and kidney diseases associations. We try to have our project to have the real outcome, and we also hope to produce the important outputs. And talking about the monitoring, now we come to the project implementation. We dispatch a project manager, John. He closely work with Dr. Moray and to coordinate all the activities. And what we have learned up to date, that is every country has different situation, and we need to respect the ownership. So that is why every time when we discuss with Ministry of Health, we always want to know. For example, we would like to do survey, but what is the best practice? For example, at the first beginning, we think that we should go to a mobile clinic to collect the data. And then we found that actually most of the population who will go to the mobile clinics, the ladies, the females, and the elder people. But a chronic disease, actually, we should focus on men. Because or for the drivers, they always have a long drive. So this is what we have learned. I always say that's a lesson learned, that is we need to adjust according to different countries' culture and different countries' practice. So step by step we always learn, because we always can learn from your side, and we also can find how we can accumulate or how we can have even better practice for other countries.
Now, who's going to be included in the cohort for the project?
Yeah,
How many persons have been identified?
Yeah, well, that's a challenge to begin with.
Yeah.
And how to design a methodology that will get your target population, the 100% people involved, and get that information, that target group visited and get information received. So basically, we've identified a total of 16,000 people. There's 2 levels or 3 levels that had been initially thought of. One at the community level, and that's gathering information that would be, for example, at risk groups, using the community health workers as an entry point and for data gathering. And then there's also the mobile clinic, but as she rightfully said, our culturally men work, and they may leave their villages to go somewhere else and work for the week and then come back only on the weekend, so that might be a challenge. Mobile clinics are basically designed for females, babies, vaccination, and pregnancy. Then the hospital scenario, in which we will be dealing with persons already diagnosed with these chronic conditions, especially diabetes and hypertension, to see what is their metabolic control, and if there's any existence of any renal impairment or any complication that might be already beginning. And so those are 2 different groups. For the community by itself, that's 80%, so that's 16,000 people.
Okay.
That's a big target group. Now the methodology.
And the communities are spread out throughout the country.
So there's 2 things what we can do now. If it's a national project, it's identifying, nationally we have between the ages of 25 to 50, we have approximately 106,000 people in Belize with that age range. And so more or less we have about a 50% male and female ratio. So that's another thing. So we want to get 8,000 males, 8,000 females, which would be ideal for you to have a study that is relevant
and the communities
and so
itself obviously include children, because we know we have a high risk of children with type 2 diabetes.
Yeah, so we have to, and that's the other issue, is if we come down from that age group, you say go down to the lower limit of 15 to 50, that opens up, your target group becomes bigger. And so that's
High risk.
High risk.
High risk.
Okay.
So it becomes bigger, and then we have to say, okay, each community, how many individuals within that age group live in that community? So going to the community, taking it district by district, we might have to partner with someone who has already had this experience already in doing this type of data gathering.
So you obviously need the buy-in from the public as well,
Yes.
because you'll be asking information that they don't typically get asked by their healthcare workers.
Yes, to a certain point.
And you know, most times when there's surveys, there's an education process, so people know it's information that will help them and the rest of the country in battling this problem. What are some of the key indicators that you need in terms of working with this project?
I think we will ask some epidemiologists, specialists to help
Yeah.
design all
Or they're going to
this.
design a special
Yes.
survey.
Yeah, we have an epidemiologist on board from Taiwan, along with our epidemiologist from the Ministry of Health. So we will have to finally sit down on a table and see what best suits our country and how to carry out this survey.
Now you're embarking on this project, but how long will it last? And in terms of implementation, it seems like there's a lot of putting the final pieces together.
Yeah.
What's the timeline that you're looking
So
at?
the project is a 3-year duration.
3 years.
I think we've already started on the ground. We've already done some initial conversation with stakeholders from the NCD Commission, with the Diabetes Association, the Kidney Association, Belize Medical and Dental Association, the private sector, Lumalos Hospital, KHMH, Belize Healthcare Partners, which are some people we already contacted. And so the survey that we want to do, hopefully we get on board within the next 6 months, looking at it between a duration of about 8 to 12 months before we can get that information on the ground.
Yeah, actually, we hope we can just all the times to have stakeholders to discuss. So next Monday, Dr. Lin and I will have a stakeholders meeting with all the important stakeholders to discuss what the parts we may adjust and what the parts we can have very great progress.
Yeah.
Now, in the future, we also hope to always can inform the others, other countries, and we even think that maybe we need to do the progress report in the Council of Ministry of Health, Central America.
And we've already started. We have our first identified 2 general physicians and general practitioners, 2 nurses, who have already been working with dialytic patients, will be leaving in the next 2 weeks. In the next
June,
2 weeks,
mid-June, they will come to Taiwan for 2 months.
For 2 months.
Training.
These individuals will receive training in dialysis, peritoneal dialysis, kidney disease on a whole. Come back into the country, be evaluated for 1 month here while they're working with patients. They in turn will become what we call, what they refer to as seed trainers or trainers of trainers. And so these individuals will be tasked to train and build capacity in other physicians from the districts. So the first 4 persons will be leaving in the next 2 or 3 weeks.
One of the biggest challenges, based on conversations we've had, is just the synergy between private sector and public sector in terms of what has that been like in terms of getting the private sector to actually participate fully in the BHIS?
There has been challenges. And I won't say that it's a smooth ride. There has been challenges. There also have been people who want to come on board. If I do recall, I think La Lumalos, which is also a private entity, is asking and having conversations with the Ministry of Health to come on board with the BHIS. That's only one. With the other entities, I won't be able to give you a response at this moment, but I do know that we are looking in getting them on board with the BHIS. Now, as far as the collaborating with this project, they have been on board, totally.
In fact, part of your dialysis program is executed at private institutions.
Yes. So La Lumalos, we are sending a doctor and a nurse from La Lumalos to Taiwan.
Eastern Memorial Hospital. Yes.
Yeah. So they've been totally supportive of this part.
Nice. So this is pretty much the initial phases, but I mean, it's a great need for the country, and it will open up many more opportunities to figure out where we need to work with the population especially. We want to thank you for joining us and providing this update. You're always welcome back to share some of that information.
Thank you.
All right?
Thank you.
Thank you.
Thank you.
We're going to go ahead and take a break, and when we return, we will be to talk with some young people who are members of the Belize Volunteers Club. Don't go anywhere. Open Your Eyes continues after these messages.